Okay, welcome to NG or NE tubes. What we're going to be talking about here today is there's the three reasons why an NG tube would be used. One of them is decompression, one of them is feeding, and the other one is to provide contrast media orally for a radiographic examination. So, for instance, if a patient had to have oral preparation done for, or pardon me, oral contrast for a CT scan, but they were nauseated or perhaps it's post-surgical through their esophagus or something, and they weren't able to take the contrast orally, then an NG tube would be inserted, and we could use that to get the contrast into the stomach, large bowel, small bowel, and that sort of thing. Okay, so what you're going to come across is you're going to come across a patient when they have an NG tube. Um, they're just going to be basically kind of secured, if you want to call it that, to the patient's gown, and it'll just be by a bobby pin. So what tends to happen is, again, too, that will cause artifact. So when we take any kind of X-ray, we want to make sure, if it's a chest X-ray and that bobby pin and perhaps the rest of the tubing there is going to be in the way, that we very gingerly and very carefully move that pin off to the side in the shoulder area so it's not going to be shown across the chest. Okay, all right. As far as the NG tube itself, it will be, we don't we don't actually perform insertions of NG tubes, but when it is done with lubrication and what have you, and the patient's encouraged to swallow, and that helps kind of do the drinking mechanism or whatnot. So the nasogastric tube, what's really important is that anytime we are, you get a requisition, and it's post, what it'll be just a regular chest x-ray, and this is where we have to really pay attention to our requisitions, and we also have to make sure that information is provided as to why that x-ray has been ordered. Okay, so the clinical history or any previous history or what have you. So what tends to happen is when the NG tube is inserted, they need to confirm placement. Okay, because what can happen is that this, because of the material and the composition, these NG tubes can actually curl onto themselves. So as they're inserting it, if it hasn't been inserted correctly, it can actually curl up in the bronchi, in one of the main branches of the bronchi there. And that's not where obviously you want it, especially if this, the NG tube itself, if one of the purposes is for feeding, and they start to now, put different nutrients and what have you down, well, now we're running into serious problems because the patient will it'll result in aspirated pneumonia. So we always take a chest x-ray, just an AP chest x-ray, to confirm nasal gastric tube placement. Okay, so where does that come in? How does that affect you guys? Okay, so what happens here when we take a chest x-ray for NG tube placement, and again too, if it doesn't say anything on the requisition as to why they just wanted a chest x-ray, please follow up. Okay, please be proactive, and find out why they want that done, because there is going to be modifications in the chest x-ray if it's for an NG tube placement. Okay, so for instance, we will always have our image receptor in portrait. Okay, it's always going to be in portrait. Okay, we're not looking at the chest. So what we're going to have to do is we always need to include the very tip of the NG tube. Now, the very tip of the NG tube is radiopaque. Okay, we also can, if we examine this a little closer, we can also see that there's numbers, there's indicators. Okay, and what happens is that if there has to be an adjustment in the placement of that NG tube, then they're able to very accurately make that adjustment, whether they have to advance it or pull it back based on these indicators. But the tip itself will be radiopaque. And so when we take a chest x-ray, doesn't matter if the patient's as wide as can be, we always do it with the image receptor in the upright position. We also need to ask ourselves, based on the typical location of the stomach, are we going to have the image receptor, up above the shoulders, or is it maybe going to have to go down a little bit lower? Well, it's going to have to go down a little bit lower to ensure that you include that tip. Okay. Also, too, if it's going down lower into the stomach, and we think about the different body habituses, we want to say to ourselves, okay, there are some body habituses that we need to make more technical factor adjustments to. So we're going to possibly have to increase our MAS. maybe even the KBP. All right, so if you have a full figured individual, it's kind of almost like a hybrid, chest and abdomen. And we're not worried about the chest. The purpose of taking this AP chest x ray is for NG tube placement. Okay, so please consider adjusting, okay, your image receptor as far as superiorly and inferiorly. Also, to please consider the technical changes that you're going to have to make. Okay, in your notes, there's tons of different types of NG and NE tubes. You will be required to, because here's what will happen is that they'll just put the name of, they'll say, oh, under the reason they're doing this, 11. Well, what's 11? Oh, it's a type of NG tube. So you need to know those, okay? So if you guys are wondering, do we need to know all the different? Yes, you do. You do need to know them, okay? And yeah, other than that, these will come in kind of a few different sizes and shapes or what have you, based on the patient. Pediatrics would be obviously quite different and stuff like this. But yeah, please, as far as from our perspective, make sure you consider those adjustments that we are required to do. Okay, thank you.